I do not think that most people know what an interventional cardiologist is. I think they figure that out once they're in the hospital. And I think it's about time that the population knows that we are in this fight because we also have, I think, a big role in terms of public health.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. Welcome to another Monday, and thanks for tuning in. My guest today is someone who's been on Parallax, was on Parallax for season 1, then recently published a children's book on a disease condition within cardiovascular medicine, an inherited cardiomyopathy, hypertrophic cardiomyopathy. He's the international expert on the condition, with the patient advocate, and now comes back as in the capacity of the incumbent, I should say the incumbent, not the incoming anymore, because he is now the president of Society for Cardiovascular Angiography and Interventions. I don't think the name needs an introduction. Dr. Srihari Naidu is professor of medicine at Westchester Medical College, Westchester Medical Center and New York Medical College. He's a tenured professor of medicine. He is an international expert in hypertrophic cardiomyopathy. His other area of professional expertise or expertise within cardiovascular medicine is cardiogenic shock. He's written seminal documents for the society to progress the field of cardiogenic shock. And is a personal friend, and I call him a mentor and a friend. The mentor goes in first, and then a friend, because he has, for me, been someone who I relate to on the level of a human being. And we were just talking offline as to how courageous, I think that's the right word, he is in putting forth the vulnerable aspect of being a human. All of us are human beings at the first place, and I can go on and on, but I'm going to let him take the pedestal here. So without much further ado, Dr. Naidu, welcome back to Parallax, and thank you for doing this for us on a Sunday at the helm of a presidency. I was just at your dinner this past weekend. Thanks for having me on at your presidential dinner.
Thank you, Ankur. So it's a pleasure to be back. I think this is my third or fourth time to be on Parallax. And first of all, congratulations on this podcast doing extremely well internationally and having the follow through and the persistence to keep moving it forward. I think you've had many amazing guests, and you span clinical to non-clinical topics. And I think that is very interesting for our society and our colleagues to hear because it is important to put all of this together in terms of how people move their career forward and how they move their life forward. And I think these types of discussions are very fruitful. So again, thank you for having me, and I'm looking forward to discuss some of the topics that you have in mind.
Well, thank you. Thank you for being a guest. Thank you for being a supporter for the platform. Thank you for the kind words. I want to start by, first off, I think many amongst our listenership would want to hear your journey to becoming the president of Society for Cardiovascular Angiography and Interventions. I think I'm sorry to have missed your presidential address the next evening because I flew back that morning, but I had access to the slides that were shared by those who were present, listening to you live on X. So I think we would start from there, and then I have a few more questions to ask you.
Absolutely. So I think put a lot of time and energy into what I wanted to talk about, and I didn't actually create a speech, but rather I created some slides that would help guide me through what I wanted to say. And of course, I want to talk about the society, what it has meant to me, how much it has grown, and what the vision is for the future. Certainly during the next year, when I'm at the helm, along with the board of trustees. But I also want to make it a little bit more personal, and I think there's a couple reasons for that. One is that I think my story is somewhat unique. in this country and academia of medicine, um, partly because, of course, I'm this. If you start at the basics, I'm the son of immigrants, and I think being born and raised in this country, I have a little bit different experience than even the more recent immigrants from India or South Asia, and it's partly because when my parents came in the '60s. First of all, they were called to come. This was a time when, obviously, civil rights movement in the country, but there was a big call for educated workers to come in medicine. And so my parents were part of that first wave. My father first, and then my mother. And what that did, however, is that when I was born here in the '70s, I was born here at a time where there really weren't any other South Asians. There were literally zero everywhere I went. And it's very different than people growing up today, first generation, where they have lots of other people from their background. So because of that, I literally only had one other South Asian in my entire high school. I mean, that is how rare it was at that time. And it's not relative to, where I was living, but rather there was just few immigrants in this country from the South Asian subcontinent because of the fact that they were part of that first wave. It really came a lot more in the '80s and '90s, of course. So that means, however, that I grew up in an environment where I did not have as much culture from our motherland culture. I had 100%, 110% American culture, which I truly enjoyed. And I think I started my talk mentioning how I was really a kid of the '80s, living a typical American life, which I really enjoyed. I had a very sheltered upbringing in terms of a lot of love and attention, and also a lot of autonomy to grow. And so I had a lot of activities and things I was interested in. Obviously, I was doing well in school, but really I was somebody playing around and had a lot of fun. I sang in an a cappella group. We used to compete. I also played paintball, used to compete, traveling to other states to do tournaments. In the infancy of the paintball era, I used to buy and sell a lot of comic books, and so I did a little bit of hustling on the side just to make some money. Indian parents don't give allowances, so basically, I had to find my way to make some money. When I was younger, I had a paper route. Typical American kid riding his bike around, throwing papers at doors and collecting the funds. I used to shovel the snow in the winter to make money, $20. That's how much we made, but backbreaking work. So really kind of hustled and did the American thing. And I think I became very well rounded at that time. I had a lot of friends and I was a very happy kid. But my parents really allowed that to happen. And I don't think kids realize that in retrospect, how much your parents sort of shelter you and make sure you have an environment that allows you to grow and, have courage and confidence and ambition and vision. So I think a lot of that started there. And then I jumped to a slide really all the way forward where I was finishing fellowship at University of Pennsylvania, and I showed certainly a lot of colleagues there, and even people who are in the audience now cheering me on, and also people who were, my co-fellows had come from Phoenix to come see me, and other people like that. So I think there's something I mentioned in that slide, which is that I termed an acronym LINK, LINK, which is the first time I ever mentioned it, but something I just made up that I think summarized my fellowship, and I think might be a way for other people to see what they might want to do with their career. So LINK is L for leadership, because I learned that there's some power to being a leader, and it's not necessarily a power that is internal, meaning it's not coming to you, but rather what you can do with that power. So I learned from my faculty and attendings there that being a leader means that you have autonomy to do something, but also responsibility to do something. And I think it was during that fellowship that I realized that if you're going to do high quality work, it's important also to do for others. And as a leader in interventional cardiology and in medicine, you certainly can do for others in a much grander scale. And so that was something that I took from that. I is for innovation, because it turned out that I was, good with my hands, and I realized that there's some power in, combining your hands and techniques with innovation and technology. So that's what the I was for. And it was for networking, which is that I think I've built my career and my life around essentially making friends and finding the common ground where we could do things together. And if you think about it, that could be where you find hobbies that are interesting to you, but it also could be where you find research ideas that you can publish on, or where you can find ideas that you can make a product on and innovate on. So networking is really a large term for finding common ground with lots of different people that allows you to progress in life in all the different spheres, clinical and non-clinical, to kind of feed your soul and also feed society if you can do that and if it's meaningful to you. And the last thing is knowledge. So I came away from Penn realizing that you can't do any of these things unless you have the truth or unless you have the knowledge, the wisdom, the experience. And that's a broad term, meaning that over time, you get more of some, you get less of the other, but it always starts with, kind of a search for the truth and then using that throughout your network and innovation and leadership abilities. So that was Link. And so at that point, I moved into sort of how I got more involved. And the theme with that was that, first of all, everywhere you go, you should try to learn and you should try to grow. And that oftentimes means that you're going to have, I wouldn't say mistakes, but certainly things where you might perceive yourself to have failed. But really, it's really learning. So failure is just learning, meaning that you've realized you made maybe a misstep or you took a wrong path slightly, but you can right yourself or you can find the best from that path. And that's really what life is about. I mean, nobody has a blueprint that you get from A to Z perfectly, and nobody does. So I just took people through the fact that I certainly changed jobs a few times, that some of those were me being a young, impetuous person, thinking that things must be better somewhere else, but also realizing as you go through it that it is better in some regards, but maybe worse in other regards. That's something you have to learn as you go along. But I also talked about what else I learned during that time, which is how to relate to people, how to be a leader, how to rule or direct a lab, even though you might be the youngest person there, to manage personalities where you have to give respect, rightfully so, for the experience and wisdom other people have, even if you might have some of the skill sets as a young person that they may not have. And so I think some of those learning aspects I think are brought up. And then um, finally, I talked about SCAI. And I think, what I mentioned there is that I've been part of a lot of different organizations. And I think some of them, I think, are more, um, for lack of a better word, integrity, I would say, in terms of the being truthful to the mission. Now, everybody outside an organization is going to look at it and say, well, these people are self-centered. These people are doing things just for their own pomp and circumstance and just to get their names up in light. The reason people say that, and it's always been the case everywhere I've gone, what people feel of those kinds of leaders in these positions is that they see the benefits, they see the rewards, but they don't see the hard work and they don't see the time and the dedication, passion, and the true mission and why people do things. Because they don't see that, they just assume that all these people are doing it for what they visibly see, which is the name in the lights, the name on the papers, the name in the news. But all of that has to be balanced with the amount of work that's done. And if you look at it on balance, you can see that the people in SCAI certainly are giving way more in terms of their time, their talent, their free time, and all of these things. And they're getting back. And so I think when you put things in perspective, you'll see that there's an enormous amount of work. It's similar to everything else. If somebody looks at you and says, "Oh, you're a cardiologist. Oh, yeah, you get to be a cardiologist, make all this money." Yeah, we'll roll our eyes. Why do we roll our eyes? Because we know how much blood, sweat, and tears it took to become a cardiologist. Nobody else sees the other side. But so it's kind of intriguing to me sometimes that when a cardiologist then looks at the leadership in the different fields, they'll say the same thing. It's simply human nature to think those things. But if you look deeper, and we're all very smart, you can see the amount of work that people do. And then within SCAI, I'll say that I have come to realize that the SCAI has people like that who really are working very hard, and it's not really about them. Everything is very mission centric and patient centric, and I can't say that about every organization. Some organizations get way too big and start kind of having a life of their own, almost like an AI that becomes so big that they have a consciousness on their own. And we work very hard within SCAI, and I've specifically said it within SCAI as we've gotten bigger to make sure that everything goes back to the members and everything goes back to being patient centric, and everything else that is for SCAI's sake itself has to be cut off. And then, not that we've ever had any, but I think I'm very vigilant going forward that as things grow, they don't get too big. And we see this in everything else. We see the ABIM as it got bigger, it started great, but then as it got bigger, they found things to do just to have things to do. And I think that's one of the things that within SCAI, I'm going to try to make sure never happens. Unfortunately, we have the kinds of leaders to do that, to confirm that. So then I started talking about, where SCAI is, and certainly in the time that I've been involved in SCAI, it's gotten much bigger, but it's gotten bigger in the silos where it's most needed, as I mentioned. So it's all patient centric. So to take them one by one, I think the things that really have blossomed. Number one is education. The amount of education that SCAI has in different venues is much larger than it has ever been. Certainly, the big annual meeting, the fellows course is the preeminent fellows course now, whereas there was and there still is competition. But I think it's very clear that SCAI has the lead there in terms of how people feel and the vibe when they go there. We have the SCAI First meetings regionally now, so there's some regional presence. We have SCAI Shock, which is ballooned up, is now in 8th or 9th year coming up. And then a lot of digital presence in terms of online offerings, ebooks, webinars, podcasts, all these things, and SCAI TV and media and all those things. So a lot of education. Number two, I would say it really has grown up in terms of publications, whereas it has sort of a couple consensus statements here and there back in the day. Nowadays, it does full-blown guideline statements, and obviously with its own journal, we have an option to have continuous publication with a branding and a continually increasing impact factor that allows us to have a larger prominence. And we've really overhauled our scientific oversight committee to make sure that all those publications are very strategic. So no longer do we have random ideas that come up and say, yeah, that's a good idea, go ahead and publish that. We look at it in a very strategic way and say, well, some of these ideas are great, but they don't really fit with where we want to put our effort. We need to do these other publications, and they need to take prominence to move the field forward. So I think much more oversight in terms of that. And then finally, I'll focus on advocacy, because something I want to do in my presidency, which is to move advocacy more from just reimbursement and coding, which is important, to a more national presence in terms of impact. And so that means having larger alliances with hospitals, insurance companies, other payers like Medicare, Medicaid, having more presence on the Hill. And ultimately, what that ends up meaning is that we need to brand ourselves on who we are. I do not think that most people know what an interventional cardiologist is. I think they figure that out once they're in the hospital. But I think over the past 15 years, we are the ones really treating the heart attacks. We are the ones treating the shock. We are the ones fixing the aortic valves and the mitral valves and moving the field forward. And I think it's about time that the population knows that we are in this fight, because we also have, I think, a big role in terms of public health. Heart disease is still the number one killer. We still have variances of care all over the country. And I do think that we have the manpower to be able to treat some of these things. So part of my presidency will be making bigger connections, making it more obvious what an interventional cardiologist does and how different people should be partnering with us to change the landscape of healthcare. And so, as you know, I try to be very visible and try to build bonds outside of cardiology. And I think hopefully during this year, I'll try to make some of those connections where we are the go-to organization and the people locally to talk about healthcare as it relates to cardiovascular health. So I'm going to stop there a little bit, because I can certainly talk about more that I want to do over the year, but that was sort of my journey. I'll add one more thing, though, which is that at the end of my speech, I did make a comment very purposefully about immigration. And I think this is not a political comment, but rather me, in retrospect, looking back at my life and realizing that, hey, my parents were immigrants. And I didn't think of them that way, because obviously I already explained to you that I really thought of myself as just a regular kid growing up, and it took me a while to realize, who I was and where I came from, because I didn't have a lot of that Indian culture around me. So I think at this juncture, it's very important for me to say that that immigration, as it relates to higher education, academia, has really been something that over the past 50, 60 years has elevated this country, not least by which that it has created people like me, where I never thought that there were any glass ceilings, and certainly there are, but I always charged ahead and tried to do my best and just basically based on merit and achievements, let those speak for myself. And I think that is the American dream. And so I did talk during my speech about two American dreams. One is when immigrants come here to work really hard and try to make a better life for themselves. But I think the real American dream is to have kids that can go on and do anything and really, follow their passion and benefit society in multiple ways, like everybody can. And I think that is the true American dream for those people, and also the true American dream for America.
Wow. I mean, I have so much to unpack here with you, but thank you for going into the journey, both personally and as well as through the lens of a society like SCAI, and clearly would be an exciting year for the organization as well as for all of us, your mentees and your colleagues and your friends who've known you through the years. There's a lot to unpack here, for me as the interlocutor. So I'm going to start step by step. The one thing you mentioned when you mentioned link was knowledge, and then you brought in wisdom, and I think you made shouldn't say a comparison, but sort of like a corollary, and that is knowledge can be garnered in a short span of time, sort of like in a capsule format, but I think wisdom is garnered across the spectrum or over a span of years, as you transition from early career to mid-career, and then, at a position like yourself where, you are now the master of our society. So that's a designation, which comes after, spending a lot of time in the field and, trying to move the field and progress the field forward. As someone who transitioned from being knowledgeable to being wise, and this is certainly the capacity for this question is within the professional realm of interventional cardiology. What are some of the challenges that you experienced in the three phases of your career, and how we usually think of careers, in as early, mid, and late careers?
Yeah, I think this is something that as you get further along in your career, you can look back and try to integrate all these things. I've been talking a little bit more about what makes Sky so member centric and so willing to bring in members. And I think it boils down to something more surgical, which is that it's more of a guild or a trade than a member society. In that, once you do these procedures, you kind of get us and we understand what you're doing on a day to day. And so there's a mutual respect across the span of early, mid, and late career that we're all doing the groundwork of STEMI care, for example, as one example. Not everybody's doing that, but almost everybody's doing STEMI care. So because of that, there is a general sense that in some respects, early mid-career is very fluid, and it doesn't really matter because we're all doing the same work. You can have a 75-year-old person still doing STEMI call, and you can have a 35-year-old person doing STEMI call, and they're doing the exact same kind of work. Now, that being said, there is a difference when you do some of this stuff early career versus late career. And what is the difference is that as you are younger, you've just come out of fellowship and there's a lot of knowledge. In fact, you may have the most knowledge of all the people in our field because you just came out, you've studied, you've trained in the boards, you know all the pharmaceuticals, inside and out, you know all the techniques because you've done a lot of cases in that 1 or 2 years. You have all the tips and tricks, and you have a lot of muscle memory of what's going on right now. On the flip side, as you get further along, you have a lot of wisdom of what works, what doesn't work. When do you need the most aggressive equipment? When do you need less? And the fact that maybe you use less equipment, less aggressive, you have less complications. Whereas the young person may say, oh, well, I'll do EBU or a more aggressive guide for all of these things because I know that I 99% have a much more efficacy. Well, the wise person will know that yes, you have more efficacy by always being aggressive, but you have a lot worse complications by doing that. So the wisdom is really right sizing the guide and the choice of equipment for the difficulty of the lesion. So that's just one example of how early in your career you do more of a shotgun approach, and later in your career you have a more elegant choice of different ways to attack a lesion. So, and people oftentimes also look at it in that as you get older, you get a little more conservative, probably because the accumulation of complications weighs on you, whereas the accumulation of victories um, wane over time. Whereas when you're young, the accumulation of victories are very uh, empowering, whereas the complications are few and far between. So I think oftentimes, and I've said this to people, that mid-career might be the sweet spot where you have enough experience to know what to avoid and what not to do, and how aggressive to be and how not aggressive to be. Whereas, um, when you're too young versus too old, you have to be wary of these things. So the youth should make sure that they're not being overly aggressive, and the late career should make sure they're not being overly conservative. So I think these are lessons for both, and I think the fact that both sides need lessons really is very equalizing in terms of how we respect each other. So I think that's part of the reason why feels like interventional cardiology can be very respectful of each other no matter what level they're in. And I certainly, when I walk around SCAI, I see residents and fellows and early career, mid career, and late career, and I treat everybody with the same respect. And that's not just the way I was raised, but rather because I know that we're all doing the same work. And I think the power of all doing the same work is a very equalizing sentiment and viewpoint. So I think that that's part of it. I also think that everybody has to learn from each other. That means that early career people should be bouncing cases off mid and late career people to make sure that it's reasonable to do, and B, that they have the skill sets to do that, and C, that there's help should they need it. So it's more of a team approach. And on the flip side, the older people need to continue to learn. So it is tough as a mid to late career person to turn to your early career person and say, "Hey, I didn't train in ultrasound guidance. Let me see it. I know it's supposed to be easy, but let me see it." Or I didn't train this complex antegrade approach or retrograde approach to CTO. Can I scrub in with you because you're the one doing all these things? And yes, I know that I'm 20 years older than you, have a lot of experience, but I don't have any experience at this. And so I think that as you transition through your career, you have to have some humility about that, but also you don't need too much humility because you have to keep in mind what you have that you bring to the table when you come there. And that's a lot of wisdom and experience being there for just a long time and getting through that without so many major complications that that it has hurt you. And that type of wisdom is very helpful to the junior person, just like their knowledge is helpful to you.
Yes, it's a great equalizer, and cath lab is a great equalizer. Just like life, and I I couldn't agree with you more that the mutual respect just comes because of the nature of the work that we do. And so which I think is a good segue, because the nature of the work that we do, I don't think is well represented in society. I mean, to your point on advocacy, I think overall, if interact with people and are social, which I know you are, you sort of get a sense that people don't really know what we do, don't really understand what we do, and that is in stark comparison with some of the other professional, either broad specialties or subspecialties within medicine. I mean, people know about plastic surgeons, people know about orthopedic surgeons, people know about cardiac surgeons, people know about neurosurgeons. I think we do pretty intricate work ourselves. As proceduralists. In the throes of a STEMI or cardiogenic shock in the middle of the night. Waking up. Reaching at it within a certain time. In hospital premises and doing these cases. Um, I think it's. I mean, obviously, I'm sort of preaching to the choir, but I think it's pretty neat work. That's why I chose to be in this field. Um, so two aspects to this question, Dr. Naidu. One, why do you think that is, that this awareness is not there, or maybe it's the perception from us, like you and me, that it's not there, but maybe that it's there. But I sort of agree with you that it's not there from what I've experienced. And two, how do we change this? Couple questions.
Yeah, so I think it's not there for a couple of reasons. One is that we have not put the effort in. It's a complicated term, interventional cardiology. People are not sure what that means. There hasn't been that much national visibility about it. And I think that because we come from within other societies, meaning spinning off from American College of Cardiology and the American Heart Association, those two organizations, and especially the American Heart Association, has really taken the public-facing aspect of cardiology. So if you ask people, who's taking care of heart disease, they'll say cardiologists, and this is true. But there's no understanding that the people coming in at the middle of the night, and you and I are on call today, so we may have to go in. I do have a case later today, so we have to go in on holidays and on weeknights and anytime to take care of patients in the throes of a heart attack or any other emergency where their blood pressure is down or or they can't breathe or something like that. We're the ones who have to go in, and I don't think that. I want people to know about that because we want to be patted on the back, but rather it goes back to what I was saying before, which is that because we have the potential to make a difference nationally, the first step in that is to making sure people realize that we have a seat at the table. And so I think we need to be at the table because we are the ones out there doing that work. With all due respect, my general cardiology colleagues are not the ones coming in. They're on the text thread with me, but really it's us coming in and doing this work. And so if you want to change societal outcomes in some of these disease states, you're going to have the workforce actually doing the work. So I think the visibility is important so that we have a seat at the table, and the table meaning national politics and national government and payers and all of these things, which are determining how people across the country are getting their care. And you and I know that the care is very fragmented for a number of reasons. A lot of it's determined by different states. There's different monopolies of healthcare systems, different payment systems. There's different socioeconomic status and cultural problems and different ways we treat different ethnic groups and whatnot. So there's a lot of variances in care that can be solved by having improved access to people like us, who I think medicine in general are people who will go past the socioeconomic status of the person in front of us, no matter if there's two people in front of us, one extremely rich and one not as rich. If the one who's not as rich, if they're sicker, is getting the care first. And medicine is the only place that kind of does that, and so we have a ability to, broadly improve access and improve outcomes for the population. So we need to be there. So how do we do it? So I have a two-pronged approach for this year in my head that I'd like to do. One is that we have a workforce of interventional cardiologists who certainly can promote what we do. And I do think it's time for us to be proud of that. I don't think we should be going around explaining what an interventional cardiologist does. I think people should recognize and realize it, and we should be proud of that. So one thing I did, and it's a simple thing, is I rebranded the SCAI baseball hat, which is just a cap people can wear because I wear a cap all the time. And so I modeled it after my cap. In fact, I had the company send me different examples. I made sure it's the one that's high quality that I like, and I had the logo on it. And I put the logo of SCAI on it without the word SCAI at the front. There's a small SCAI at the back, but in the front, it's just the logo, which, as you know, is a pretty kick-ass logo, if you ask me. And it's interesting because if you have a hat with just a logo on it, people tend to ask you what that is. And all you got to do is you got to say that, this represents interventional cardiology. I don't care if you're saying SCAI or not. SCAI is really all of us. Rather, I'd like it to represent interventional cardiology in related fields that work with us in the lab. Then people will ask you what that is. You'll say, well, we're people who do procedures with our hands on heart disease and all kinds of heart disease, and we're also the ones that come in, take care of these patients, take care of all of us. And I oftentimes explain to people that wherever we're sitting right now, somebody here has a heart attack, some interventional cardiologist is being that person in the hospital and dropping what they're doing to do that. And it's not so that we get, again, to get patted on the back, but for people to appropriately recognize the work we do, just like they recognize the work that a fireman does or a police officer does or somebody else. When we're in that role, we are basically a servant to society. We're not getting for that. This is something that's wrapped into our salary for the most part for most of us. So we are doing a public service, and I think people who do public service should be recognized for doing some public service. We certainly don't get the public benefits of other fields, so I think it's reasonable for people to know that. So that's number one. Number two is during this year, I'm going to be charging our advocacy committee to look more broadly about alliances and argument when we get to those different constituents to say why interventional cardiology is who they need to partner with, in addition to other organizations and even other societies within cardiology, why separately they need us, because we are the workforce that can really tackle some of the big problems in society, namely heart attack and shock and aortic stenosis, things that are really differentially killing people across the country, including vascular disease and potentially stroke as well. So I think we need to have people look at us and move their eyesights away a little bit from AHA and ACC, which are also on the same missions, but don't have the levers that we have to actually mechanistically move that forward. In other words, if you talk to American Heart Association about what they've done to society, they will essentially say that they've decreased the heart attack death rate. And you and I both know that, yes, they've done that, but they wouldn't be able to do that without us. So I think at some point, it's very reasonable for us to make their case that we need to be at that same table with them when these ideas are coming up, so that we can institute some of these things and make a difference. So I think over the next year, and then hopefully going forward, I can look back 10 years from now that everybody knows what an interventional cardiologist is, why they're important to society, how we have to make sure we have a robust pipeline for these people, how we have to make sure that they're all over the country to elevate care across the board and hopefully minimize mortality from cardiovascular disease.
Yes, super, and more power to you. And certainly, I really like the focus that the specific spotlight that you've put on advocacy, and for the reasons you just mentioned, is crucial. A couple more themes I want to talk to you about, and this is from our discussion earlier. One was, when you were put in life, or as an opportunity, you got the opportunity to lead the lab at Winthrop when you were younger in comparison with some of the other colleagues in the lab who were working with you. I think there's a lot to learn from that experience of yours as to how to navigate that dynamic of being the younger person as a leader, trying to lead and build a program. If you can sort of share with us, what were some of the insights you learned about being a leader, but also about being there are two aspects to this one. One is a leader in that position, trying to lead someone who's senior to you in terms of the number of years spent in career or in tenure. And then two, as a person, what were some changes that you had to make, or reflect or self-realize as you were doing that job?
Yeah, I think some of it I've already said, which is that it's all retrospect. I came into that job thinking that I'm highly accomplished, highly capable, high energy, and all of which is, I think, true. But nobody else knows that, right? And so when you come into a new job, you have to prove all those things. And you have to also look to see that there's always going to be a perception that you're younger, and that even if you can prove a lot of those things, you will not have the wisdom and experience ever of the people who have been there a lot longer. That's just simply part of life. And I think we don't like to hear it as a young person that you just need more time or need more age, because it's immutable. And something that's immutable is something that is very upsetting to people because it's something that they can't change, and it'll always feel like something that makes them inferior, and that people are doing that on purpose, but they're not doing it on purpose when it comes to this. There is actually something that you can't get rid of by just being young. You have to go through it, and you have to learn. You have to have the case volume and the volume of time to realize some of these things. It is true. We don't like to hear it, but it is true. So I think recognizing that is important, because then you can focus on the areas that you can do and that you can shine on and that you can gain respect. Okay. So one of it, and the most important one, is basically you have to be really good in the lab. And I've come to the realization that not everybody is good in the lab. I mean, we all think that if you graduate from interventional cardiology, you have to be a superstar, but everything's on a curve. And then there's always some people, everybody thinks they're amazing, but there's some people who are less so and some people that are gifted. And you don't really know where you are. So you need a good people around you, a good number of people around you to kind of tell you what you're doing. Are you having good judgment? What is the perception of your abilities? And that's not easy to get from other people. So you can understand it by seeing how people relate to you, what kind of cases they give you. Um, are you getting into trouble in your local hospital? These kinds of things. So the first thing is you have to make sure that you're good, because at the end of the day, senior physicians will respect somebody who's busy in the cath lab and good in the cath lab. So fundamentally, if you have that and you don't skimp on that, you'll ultimately win everybody over, even the naysayers. So, or even if they don't want to win, even if they don't want to come onto your team, they at least can attack you on that. If they can attack you on that, then you're in trouble. And I have seen that happen nationally, where if somebody's actually not as good as they think in the lab, ultimately they get brought up in terms of the medical board or something that happens. And because they're doing too much or getting into too many complications, and they don't really realize that they're not right sizing the kind of procedures they should be doing. So number one, you have to be really good in the lab. Number two, you have to be a good leader. And I think that a lot of people take on the directorship of a lab and actually are not leading. They just take the title and they basically do what's handed to them in terms of signing protocols and policies that are otherwise written and renewed and whatnot. But they don't really dig deep into the lab and do the work. And so I dug deep into the lab and did the work. So what does that mean? That means I looked at the organizational structure of the lab. What is under our purview? How do we have meetings to make sure that people are heard and that the things that they're upset about or not happy about with the lab are sequentially addressed to the best of your ability? Finding ways to solve problems with or without resources, finding ways to build connections that allow things to progress in the lab to get more efficient, more safe, high volume, and innovative. So I worked really hard during those years to make the lab the kind of place where people came and they had all the toys. It was very efficient. Nurses were very nice, highly competent, and culture was one of no complaining and no arguing and no yelling. So that takes a lot of time. If you can build that kind of a model, people will flock to your lab, and you'll get a vibe of being a lab that is innovative and moving forward, and everybody benefits from that, even the senior people. And so I focused on those two things basically. And obviously, within that, I focused on education and training and fellows coming through and practice acquisitions and all kinds of things and working with pharmacy and budget. So I learned a lot of things during that time. But I think I got a lot of respect for taking the job seriously, is the bottom line. And I think not everybody does. And part of it is that I was not thinking I was building an academic career at the time. So I was really just figuring that I was building my clinical volume, making sure that our academic practice is seen as valuable and high quality, and then running the lab to the best of my ability with no concern about whether this is going to lead into some kind of national career. I didn't really have any ambition towards that at that time. So really, I was just trying to make my mark on Long Island.
Thank you for sharing those insights. There's a lot to learn there. For a lot of the early career people, even fellows who have leadership aspirations or listening, there's so much to garner. There for future leaders. The second topic that I wanted to discuss in particular was, I think again, SCAI and the role SCAI has played in. I don't know if encouraging is the right word, but I think in maybe cheerleading our women colleagues to take up interventional cardiology. There are sessions dedicated to this particular topic, and so two aspects to this question. One is, what do you have to say to the naysayers? People who roll their eyes when they see women in interventional cardiology as a topic within SCAI or as a theme within SCAI. And two, why do you think this is important to continue to nurture? I think that, it's important to discuss this because I've seen this way too commonly now, and I'm even asking this question to you because it has bothered me at some level. I don't think we should be rolling eyes when we look at these themes or these topics. So I congratulate SCAI for what they've done within this particular theme, and I do strongly believe that we should have women counterparts as our colleagues in the labs, working with us shoulder to shoulder and taking care of patients. So I'm keen to learn more from you on this.
Yeah, so this is complicated times and a complicated discussion, but I think it's worth having because I think the way I see women in cardiology is the same way I see uh, just making sure that the best people look at interventional cardiology as an option. So, in other words, if you look at field, we want to make sure, and we meaning society should want to make sure that the best people are going into something. Period. Right? Because you want at the end of the day the best workforce, the highest quality, the most number of people doing things that meet the need of the day, which in this case is promoting innovation that betters the lives from a cardiovascular standpoint for our patients. So all of these missions, women in cardiology, women in innovation, I think it all wraps up into the same theme, which is that there are segments of the population that don't want to do interventional cardiology for reasons that have nothing to do with the field. It has to do with impediments to being that, right? So I equate these missions as across the board. Any group that feels that it would be too high a burden or something in the way that is getting in the way of their passion that would ultimately make them an amazing member of the field that is doing the mission at a high level like everybody else. So women have specific challenges. One is that there is a sense that there's a radiation exposure and it interrupts their practice during pregnancy. And because of that, and also the male culture of cardiology, interventional cardiology that had been there for a long time, were things that got in the way of a person's passion and their ultimate realization of that passion in terms of outcomes of cardiovascular health, what they can do with that passion and their talent. So everything else that gets in the way of an individual, boy, girl, whatever you want, whatever they are, different race or whatever it is, getting in the way of their full realization, actualization of their talent and their passion is all stuff that we need to get rid of. Now, you can take that for women, you can take that for minorities, you can take that for people who are relatively socioeconomically disadvantaged. These are things in the way of actualizing their passion and talent for the betterment of society. That means that interventional cardiology and other societies should look at those and find ways for programming to both affect the field so there's less impediments, and also tell those people that they should keep going on that journey because society needs them. So then that means you have to devote resources to do that. And so what people see is the resources, and that you're giving somebody some extra resources that other people don't have. But those resources are there because there are impediments for those people to get to a certain point that are not there for the other people. Hopefully, I'm explaining that very clearly. But this is the reason. This is basically what people are worried about with DEI. They don't understand that because there's a relative disadvantage or something that's getting in the way that is nebulous and hard to see, we're just attacking those things and not really, and then getting them out of the way so people can realize their full potential. And some people have less things in the way. Some people have more things in the way, and you can put those into different buckets because women as a group look at things in a different way, and certain things are more impediments to them that wouldn't be there for a man. And minorities of different types will have different, and I don't want to bucket them together because African Americans or Blacks and Hispanics and South Asians all have different things that get in the way, or actually some things that make them more privileged. So that's the vantage point I look at it. Then within that, you want to see that are you giving too much resources? Now, if you're giving too much resources, then you do overbalance it, and you might slip into a situation you're making it easier for some people than everybody else. And so I think that's where we are in society, which is that people don't know where that line is, where you're just giving enough to get rid of the negativity in the way versus giving so much that it becomes more of a net positive compared to other people. And I think because it's nebulous and hard to pinpoint, you'll have people on both sides of that saying, A, I don't get enough, and B, they're giving too much to the other people. And so now taking it back to the women part in particular, I think that in general, there's been a lot of interest, and over the years, certainly we've been training more and more women. And I'm pretty clear that we are not selecting more women to do interventional cardiology. I can take my organization, hospital, as an example. We are not going down and nurturing the women to go into interventional cardiology. I've never done that, but I'm seeing more women want to do interventional cardiology, and I think we train as many women as men now, which makes a lot of sense. And it has nothing to do with what we've given them, but just made the field so much more appealing and amazing, and showing people how they can do it and balance motherhood and whatnot. And once you show them how you can do that, we're not telling them to do the field. They naturally go into interventional cardiology. And I think that's all we're seeing. Now, at some point, it might be that you give too much support to different things, and you have to say, well, maybe that has changed and you don't need to do that anymore. I'll give you another example that has nothing to do with gender or race. Let's say radial intervention. We did the SCAI trip courses. We did them all over all over the country. And then once there's enough people doing radial and we have moved the needle so everybody's doing radial, you don't need those courses anymore. So there may come a time where you don't need as much of the women in innovation, women in cardiology, because there's enough people and those impediments are gone. And then those organizations within SCAI and other areas will either be sunset, just like we sunset aspirin for STEMI care, right? Everybody's getting it. It might be sunset because you don't need that, or they may mutate into just sort of organizations that focus on other areas within that, which is, still things on how to balance work life by your gender or other things, or maybe they'll morph into ways for them to benefit society and just as a way to socialize and whatnot. But I think it is good to look at all these things, and I think SCAI does look at this, and we look very carefully at what percent faculty are women, and what percent of our membership are women. We want to see that increasing to what we would consider appropriate or reasonable based on med school matriculations and what we think is happening in the field. But I think at some point, if it looks like it's too much, then we will right size. And I'll give you another example of how we right size. So we, within SCAI, we look very carefully at early, mid, and late career. And there's always a complaint by every segment that we're not putting as many of each of these in as faculty. So if there's too many early career, the late career will start complaining that they weren't invited. And when there's too many late career, the early career will say, well, you're not giving us a chance. So I think we tend to look at it very carefully to make sure that we're balancing all these aspects. And if we're having too much of one or the other, we will then forcibly make a change for the next year. And so I think this is going to be the same thing for gender and other things until to the point where it's just a natural representation of the number of people in the field.
Yeah, no, I think you handled that really, really well. Well, this has been a great podcast, Dr. Naidu. This has been, again, very engaging, very, fascinating discussion. Any closing remarks for the discussion we had, for Parallax and for the field in general?
Yeah, no, I think, first of all, thank you again. I think you always hit on interesting topics. And as you know, I'm not afraid to talk about these things. And I think that we need more of that, because people get afraid about talking about things. But if your heart's in the right place and you're willing to learn and grow, then you should be willing to talk about it. And if anything that I said can be changed or could be modified, certainly people can reach out to me. This is only things I understand over time, and that there's always room for growth. The other thing I'll say for sure is that I want people to realize that this is a great time for SCAI and us as a field. And I do want all of our interventional cardiologists to rally behind SCAI and try to make SCAI and interventional cardiology as visible and prominent as we deserve to be. And then my promise back is that the organization will feed that back to our members and make sure that our field stays vibrant and strong. Which can only lead to growth across the board, research, innovation in the toys that we have in our hands, and our ability to have a great work-life balance and a great career over time. So I think it's time for people to move over, and really every card-carrying member of interventional cardiology should be part of SCAI and understand that what you're getting out of it is not necessarily transactional. but rather in a more holistic sense about what you're feeding, our field in terms of the visibility that we have. I think HRS does a really good job of everybody being a member and being proud of that organization. And I think SCAI is right there and poised to do that and beyond.
Well, excellent. And I think what I want to offer, through our platform is, we will make certain that the cap that you designed for all of the interventionalists, we'll make sure that we have a link to that cap in our show notes for this episode, so that people who are listening and want to support SCAI and your endeavors as now the incumbent president should be able to follow that link and get a cap for themselves or for their colleagues or for their cath lab or for the loved ones.
Yeah, that'd be great. So one thing I did, which I think is unique, is I bought 3 other caps that are coming soon, and I bought them for my 3 colleagues. Why? Because they're not all members of SCAI, but I don't care. I'd like them to be, but I want them to wear the hat, and I want them to feel that they're getting something, and no better way to do that than to get it for free. So I encourage interventional cardiologists listening, buy the caps for everybody else in the lab, so that they'll wear it.
Yes, so I will do that for my for my colleagues and for my cath lab personnel. Again, Dr. Naidu, this has been great. Thank you for doing this for us. And for those of you who are listening and have feedback for Parallax, for Dr. Naidu, do write back to us. We take feedback seriously. And, until other Monday, thank you, everyone.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.